Hello people, this is a video about an important difference between intra-articular fractures and extra-articular fractures. So basically an intra-articular fracture is a fracture that is going into the joint and involving the joint. So in this representation, the fracture is on the tibia, and it is going from one part of the bone in the lateral condyle of the tibia at the plateau of the tibia from the bone to the joint, and it is entering the joint space. So an intra-articular fracture. The significant problems that arise with this fracture are actually arising from the damage of the cartilage in the joint. The second possibility is an extra-articular fracture. As we can see here, it is going from one side of the tibia to the other side of the bone, and it is not involving the joint. So the difference is obvious, and it is also obvious that intra-articular fractures are more complicated, and they have a significantly more serious outcome, because they can have short and long-term complications, and they most oftenly have these complications. And these fractures, the extra-articular, have a better chance of healing properly, and this healing is often with only minimal or even no complications if the treatment is done properly. The treatment in here is very complicated, and most of the time these fractures don't look like this. This would be a very simple fracture, and it would be relatively easy to repair for a skilled surgeon. But these fractures can also have multiple fracture lines and multiple fragments, and then the possibility of repairing them properly is not that high, and it is very hard to achieve the normal anatomy again after the damage is sustained. So why are these two types of injury so significantly different? Normally, if we would take now a cross-section, a frontal cross-section from here, this is the knee joint. The knee has the meniscus, but all other structures are present in our synovial joints. First of all, we have the hyaline cartilage. So this hyaline cartilage is about 2 to 4 millimeters thick, and it is lining this smooth surface of bone. So this would be compact bone, and this would be spongy bone. The hyaline cartilage is a thick, shock-absorbing cartilage adhering to this smooth side of the bone. And this is how the things are arranged normally in a physiological joint, a synovial joint. And here would be in the joint space a little bit of synovial fluid, 3 to 5 milliliters. So the hyaline cartilage allows the normal movements that are painless. And these movements are only possible because this cartilage is very smooth. If you would enter with a camera into the joint, you would see that there are no bumps in this cartilage. It is a very smooth, shiny and white surface. But what happens if we have an injury like this? So for example, the patient is hit by a car and he sustains this fracture of the tibial plateau. So this is a simple fracture. In this fracture, we have the fracture site, and it is splitting obviously these two parts of bone, and when it is entering here in the joint, it also disrupts, for example, one side of the cartilage, the articular cartilage. Of course, we will have bleeding, separation, and now the body needs to repair. Of course, if this gap is, if it is wider, there will be a huge scar here, and this huge scar will make problems in joint movement. The problem is that the hyaline cartilage has actually no blood vessels. It is only supplying itself from the inside of the joint, from the synovial fluid, with nutrients. And in adults, it cannot be repaired. So there are some methods, but no perfect method is yet found to repair hyaline cartilage. The end line of repairing it when it is damaged totally is a joint replacement operation. Now, when, for example, this heals, even with an operation that aligns these, if it brings these parts together, and if this only is a few millimeters, we will have, of course, a better result. But sometimes, or in many cases, that cannot be achieved. And even if it is achieved, we will have some scar tissue. And from this image, in a few months, when the fracture is healed, we come to this. So we can now appreciate that we have the body has made a scar here, and the normal hyaline cartilage that is present here was replaced by scar tissue. And over time, as the joint moves, this upper hyaline cartilage that was not damaged, over time it will also get damaged. And all of this will have a patch of damage where there will be no hyaline cartilage. The cartilage has no nerves, so the patient will not feel pain until the bone is exposed, because the bone, the periost, will then, when it rubs on the surface of something else, it will create pain. In years, so in many years after the injury, the patient is walking, the surfaces are rubbing against each other, and then we have this problem. So the cartilage gets eventually degraded or destroyed. This can happen in patches, or a higher percentage of cartilage can be destroyed. If the patient continues to walk like this, it will come to an ankylosis. An ankylosis means that the joint is, there is no more movement in the joint, and both the bony surfaces are actually fusing together. And that is actually the end stage if you don't operate. But what happens when the cartilage is destroyed? The patients have a decreased movement possibilities in the joint. They have pain, and they are actually operated, and the joint is being replaced with an artificial joint. And that operation is actually very risky, but it can restore a part of the joint function for adequate functionality. So here we can see the long-term complication. Even the meniscus is degrading, and we see that the joint space is also narrowed because the cartilage is gone and the bones are starting to fuse, and the bone is rubbing against bone, and that is creating pain, and that is also limiting the amplitudes of movement. The second possibility is this extra-articular fracture. So the extra-articular fracture, it is obvious that it is only involving bone, and in contrast to the hyaline cartilage that has no vascular elements. It is avascular. The bone has good vascular possibilities. In a healthy young adult, it has an extremely good capacity of healing. So we can see, if we would take a section of this part and zoom a little bit in, we can see when the fracture happens. Here we have the compact bone, and here is the spongy bone, and here is the fracture, and here is a hematoma developing. So if this is aligned anatomically, immobilized or operated and immobilized, in a few months the bone will heal, callus will form, and we will have maybe a little bit deformed compact bone, but that isn't that important, and the patient will not feel it. But the fracture will maybe be visible, maybe it will not be. In children, for example, after a fracture heals, after a few years, it can't be distinguished that at that part of the bone there was a fracture. So the healing potential in these fractures is actually very good. And that is the difference. If you see a patient, and if a patient comes to you in the emergency room and has an intra-articular fracture, even if it is simple, this poses a significant risk for arthrosis in the joint. And if a patient has an extra-articular fracture, it is also bad, but it is better, much better than an intra-articular fracture. And I repeat, this is only a simple fracture. Fracture can be much more complicated than this, with more fracture lines, and then the operation is much more complicated, and the long-term projections are also not that great. Thank you.